I'm Charles Yang. I am going to discuss today the advanced topics in anesthesia for pediatric anesthesia. I am an assistant professor of anesthesia at Children's Hospital of Pittsburgh of UPMC. I have nothing to disclose today. I think that what we'll do is we'll begin with discussing some of the emergencies that occur in newborns. These are the basis of pediatric anesthesia and are very important points that are focused in any form of review. First, we'll discuss some diaphragmatic hernias that occur in newborns as the presence of tracheoesophageal fistula and esophageal atresia, neonatal lumbar emphysema, pyloric stenosis, necrotizing enterocolitis, ophthalmoseals and gastrohesis, respiratory distress syndrome, as well as myelomeningocele. Diaphragmatic hernias have an incidence about 1 out of 5,000 births. It usually occurs in the left side and is 5 times more likely than the right. And about 80% of the time it occurs in the foramen of Vodaclic. Of concern is the presence of contralateral pneumothorax that will occur on the other side from the diaphragm. Sometimes prophylactic contralateral chest tubes are placed. Of concern physiologically is the decrease in peripheral vascular resistance, which results from increase in partial oxygen pressures as well as increase from partial pressures of CO2. Tracheoesophageal fistula and esophageal atresia is also a very common pediatric occurrence and a concern for pediatric anesthesiologists. Incidence range from 1 out of 3,000 to 1 out of 4,000 births. In addition to the tracheoesophageal fistula and esophageal atresia, you also have 20 to 30% other additional congenital defects that can occur. And of these, 35% of them are related to congenital heart disease. There are multiple anatomical variations associated with this disease which occur together, usually mostly in type B, C, and E. 90% of the cases are type C. Again, this is a diagram of esophageal atresia. Type C is the most common variant of this disease, over 90%. Type A, demonstrated all the way to our left, shows no esophageal communication with the trachea. Type B, there are upper segment communications with the trachea. Type C, again the most common tracheoesophageal fistula present, has a lower segment communication to the trachea. Type D, both upper and lower segment communicates with the trachea. And in type E, the last one on the right, no esophageal disruption, but has tracheoesophageal fistula. Type F is not shown. It usually is only the presence of esophageal stenosis without the disruption of the esophagus. The management of the patient with tracheoesophageal fistula, esophageal atresia, is usually done by awake intubation, but it's not necessary. But it's important to maintain spontaneous ventilation until the fistula is ligated. Therefore, avoiding positive ventilation, which will avoid gastric distension. And this can also be helped by placing the tip of the endotracheal tube beyond the fistula. Neonatal lumbar emphysema is the hyperinflation and the progressive air trapping caused by expansion of an infected lobar. It usually occurs from the age of newborn to 6 months. The anesthetic management is important for a smooth inhalational induction and again minimizing positive pressure ventilation. Pyloric stenosis is probably one of the most common GI abnormalities present in the first 6 months of life. Controversy associated with risk of maternal exposure to macrolides exists, and there is associated birth defects including cleft palates as well as esophageal reflux. Diagnosis is made by palpation of an olive-sized mass in the upper abdomen, which is felt best when the patient is anesthetized. An ultrasound, false positive studies are rare, but false negatives can occur approximately 20% of the time. Initial therapy is always to replete intravascular volume, correct electrolytes and acid-base abnormalities, usually using 5% dextrose in 1/4% normal saline with 40% micromolars of potassium, usually running at 3 liters per meter square per hour. This is not a surgical emergency, but it's important to treat the dehydration and the acid-base abnormality prior to taking to surgery. There is high risk of aspiration with this procedure. It is commonly the patient's stomach is emptied prior to induction, and a rapid sequence is usually done, but not necessarily all the time. The cardinal features of pyloric stenosis includes a non-bilious projecting vomiting, visible peristalsis, hypochloremic state, as well as hypokalemic and metabolic alkalosis. Usually the presentation is between 2 to 8 weeks of age, and the anesthetic consideration again is to preoperatively repair any evidence of dehydration, acid base, and to be especially concerned during induction for aspiration. Necrotizing enterocolitis is a systemic process and is analogous to sepsis. It leads to intestinal necrosis and increased intestinal permeability. Initial treatment is non-operative. Mortality is somewhere between 10 to 30%. And intraoperative concerns include coagulopathy, opiate-based anesthetic to minimize cardiodepression, and hypotension. Inotropic agents might be necessary. There is a large fluid shift that occurs, so fluid management is important, especially considering the small size of the patient, and hypothermia. Ophthalmocele and gastroschisis. In ophthalmocele, there's a central defect of the umbilical ring. So this herniation leads to an enclosed visceral peritoneum, and usually is larger than the gastroschisis in comparison. The gastroschisis is an abdominal wall defect, usually to the right of the umbilical cord, and is usually due to the ophthalmomesenteric duct artery disruption by the 5th and 8th week of gestation. Because it is not enclosed in the umbilical ring, there is no peritoneum, there is no overlying sac. The size of the defect is usually less than 4 centimeters, smaller than the ophthalmocele. And most of the time, almost all the time, it is right of the umbilicus. Anesthetic consideration in this group of patients is the concerns of abdominal compartment syndrome, which can lead to impairment of respiratory function and even the diminishing of blood flow to the viscera. It takes tight coordination with a pediatric surgeon to identify this problem. Respiratory distress syndrome occurs when surfactant is insufficient, usually in the light of prematurity. Clinical features include tachypnea, retraction, grunting, desaturation, respiratory and metabolic acidosis, diffuse reticular granular patterns seen on the chest X-ray. It is important to replace surfactant, and this is usually done prior to delivery with beta-methicillin, which is given to the fetus through the mother before the 36-week gestation. There is also post-birth the availability of commercial available surfactant. Treatment medically is done by nasal CPAP or mechanical ventilation. Myelomeningocele is a bulging sac containing meninges and neural elements. This is a true surgical emergency and requires prompt repair to prevent infection. It is important to avoid pressure on the sac since the sac contains neural elements. It is important during induction to induce either in a lateral position or the use of donuts. Like most pediatric neonatal emergencies, we consider awake intubation as an option. Medical problems and anesthetic issues in pediatric anesthesia include upper respiratory infection, bronchopulmonary dysplasia, cystic fibrosis, muscular dystrophy, myotonia, development delay, cerebral palsy, autism, obesity, diabetes, congenital adrenal hyperplasia, klephophilia, achondroplasia, Marfan's, Morquo, osteogenesis imperfecta, trisomy 21, juvenile rheumatoid arthritis, iron deficiency, physiological anemia, sickle cell disease, and malignant hyperthermia. We will go through some of these issues in the next part of the talk. Upper respiratory infection. There is no apparent consensus on when it is appropriate to do an anesthetic after an upper respiratory infection in pediatric patients. We know that conservative approach, an uncomplicated upper respiratory infection is usually postponed 1 to 2 weeks. Complicated upper respiratory infections can be postponed as long to 4 to 6 weeks, but even this period is not guaranteed to decrease the risk of postoperative complications. It's been shown that laryngeal mask airway is less irritating to endotracheal intubation. Epiglottitis is a life-threatening, progressively rapid disease that can appear very toxic with fever and tachycardia. Cough is not as present. The pathognomonic signs are the 4 Ds: dysphagia, dysphonia, dyspnea, and drooling. Airway management is done in the operating room in case surgical airway is needed. Inhalational induction is done in a calm atmosphere and usually in a sitting position, and muscle relaxants are avoided. Epiglottitis is seen on lateral X-ray as a thumbprint sign, which is indicated by the arrow. The normally distinct epiglottis is blurred with what appears to be a thumbprint sign. Laryngotracheal bronchitis is not a airway emergency. It is slow progressing, and there is usually a cough that is barking. On X-ray, you can see on an AP view the steeple sign. This X-ray shows the steeple sign of the sharp, pointy airway due to the edema in the airway. Bronchopulmonary dysplasia. Chronic disease of the lung parenchyma and small airways with chronic respiratory insufficiency, usually due to ventilatory-induced lung injury as well as oxygen toxicity. There is persistent lower airway obstruction, usually, which requires a smaller endotracheal tube. The airway is hyperactive. Associated with this is also an increased large airway disease, including subglottic disease, tracheomalacia, bronchiomalacia. Also, a hypoxic pulmonary vasoconstriction shows a phenomenon where prior to induction, oxygen saturation is normal, but after induction of oxygen, saturation becomes abnormally low. Cystic fibrosis is an exocrine gland dysfunction. It results in airway obstruction as well as VQ imbalance. There is copious secretions as well as airway hyperactivity. Nasal polyps are frequent. Decreased serum albumin levels are noted. Coagulopathy is present as well of concern, as well as glucose intolerance. Sweating function is in dysfunction, and there is pulmonary hypertension, and all of these are concerns in the anesthetic management of these patients. The 5 clinical relevant muscular dystrophies are Duchenne's muscular dystrophy, Becker's muscular dystrophy, facioscapular humeral muscular dystrophy, Emerald-Dreyfus muscular dystrophy, and limb-grid muscular dystrophy. Duchenne's muscular dystrophy is an X-linked disorder from the deletion mutation in the dystrophin gene. which leads to complete lack of dystrophin in the skeletal muscle, onset before school age, and by the second decade of life, the patient is wheelchair-bound. Becker's muscular dystrophy is a less global change in the same gene. Facioscapular humeral disease is associated with defects in the gene FRG1, with disrupted muscular growth in the vertebrae. It is the most common of the muscular dystrophy and is most benign. Associated with little respiratory involvement, there is neck and face scapular stabilizing muscles are often weak, so the testing of muscle strength by head-raising evaluations of little value. Emerald Dreyfus muscular dystrophy is a mutation in the lamin, which is part of the nuclear matrix, and the imerin, which is a nuclear membrane protein. Cardiac conduction defects are common, dilated cardiomyopathy, as well as contracture dysfunction. There is often a fusion of the C3-C5 cervical vertebra, which results in less mobile neck, which may result in airway management difficulty. The limb-girdle mutation muscular dystrophy is a mutation in several proteins. At least at present, only 11 are known. It results in respiratory weakness as well as cardiac conduction abnormality. Anesthetic management for all muscular dystrophy is usually concerns about postoperative respiratory insufficiency secondary to muscle weakness, avoiding agents that may further depress cardiac function and cause dysrhythmia, usually recommended cardiac workup with an echo within 3 months of a anesthetic procedure, especially with Duchenne's and Becker disease. There is risk of rhabdomyolysis as well as hyperkalemia, so succinylcholine is avoided and volatile agents are used or avoided or used with extreme caution. Rarely both Duchenne's and Becker's have been associated with malignant hyperthermia, but this association may most likely be just coincidence. Facioscapular humeral muscular dystrophy, Emerald Dreyfus muscular dystrophy, limb-girdle muscular dystrophy are not associated with malignant hyperthermia. Myotonus, temporary involuntary contraction of muscle fiber caused by transient hyperexcitability of the surface membrane. These are a family of channelopathies that mostly affect muscles. There are two forms, dystrophic and non-dystrophic. They're usually precipitated by cold, stress, pain, and succinylcholine. So, for anesthetic management, it's best to avoid succinylcholine, which can lead to hyperkalemia. Risk associated with the disease is respiratory depression, dysrhythmias, cardiomyopathies, developmental delay, dysphagia, and gastric motility. Cerebral palsy is a static encephalopathy, non-progressive disorder of the posture and movement. There is usually poor muscle control, weakness, and increased muscle tone. Prone to aspiration pneumonia, there is gastroesophageal reflux and gastric delay emptying. There is usually chronic lung disease associated and frequent respiratory infection. Obstructive sleep apnea is approximately 20 to 50% of the population and is due to the bulbar dysfunction, neurogenic laryngeal malacia, and decreased pharyngeal tone. Development delay results in 3 times as much more sedation related to hypoxia. Autism is a qualitative impairment in the social interaction, impairment in verbal and nonverbal communication, which results in restricted range of interest and resistance to change. These patients are usually less able to understand the need for the procedure, less able to adjust to new routines of the hospital, are highly anxious, and more sensitive to visual and auditory stimulus. It is important, therefore, for anesthetic management to use auxiliary services to help with transition, to keep their preoperative area and postoperative area with decreased visual stimulation as well as auditory stimulation, and to decrease anxiety by having families stay close to them constantly. Obesity has become much more common in pediatric population, and just as in adult population can lead to many comorbid conditions. Obesity can lead to hypertension, diabetes, insulin resistance, the cardiac reserve is usually decreased with increased preload and increased postload. There is increased pulmonary artery pressure and increased stroke work. There is a presence of incidence of increased asthma, as well as the functional residual capacity is reduced, resulting in lower airway closure and atelectasis, intrapulmonary shunting, which leads to hypoxemia. Sleep apnea is present as well, and a higher incidence of pseudotumor cerebri, leading to headache and nausea. And all of these are concerns in the factors of anesthetic management. Diabetes in pediatric patients. Of these patients, 19% have restrictive lung disease. There is usually a classical regimen for short surgery, which involves 1/2 of the usual dose of long-acting insulin in the morning, 5% glucose solution at 100 milligrams per kilogram per hour, maintaining glucose at 100 to 180 milligrams per deciliter. IV insulin infusion for longer surgeries, usually piggybacked on insulin to glucose solution. Insulin runs usually at 0.02 to 0.05 units per kilogram per hour, maintaining glucose somewhere in the 100 to 180 milligrams per deciliter. Congenital adrenal insufficiency requires both glucocorticoid and mineralocorticoid replacement. 90% of congenital adrenal hyperplasia with adrenal insufficiency have 21-hydroxylase deficiency. Mineralocorticoid deficiency is managed with saline solution and avoid potassium. Mineralocorticoid secretion rates is not size dependent and not age dependent. Cortisol has sufficient mineralocorticoid activities to stand alone. Klebfile, fusion of the cervical vertebra, which results in limited cervical spine motility and which results in difficult intubations and airway management. There is also an increased incidence of cardiac and genitourinary abnormalities. Achondroplasia, the most common cause of disproportionate dwarfism. Poor cervical motility also requires an endotracheal size more similar to pediatric patients. Difficult venous and arterial canalization secondary to excess skin have been noted. Marfan's is an autosomal dominant connective tissue disorder. There is high incidence of aortic aneurysms. Usually there is pectus deformity and scoliosis, resulting in respiratory compromise. Venous returns can be impeded, and there can be the presence of spontaneous pneumothoraces. There is also the concerns of atlantoaxillary rotatory subluxation. More quills. Mucopolysaccharidosis type 4. Again, there is atlantoaxillary instability. There is the hypoplasia of the odontoid process of the second vertebra. Tracheal collapse during head flexion has been noted, and chronic pulmonary disease with thoracic deformity and repeat pulmonary infection has also been noted in this patient group. Osteogenesis imperfecta is a dwarfing syndrome with collagen production disorder. It is an inheritable disorder with varying degrees of severity. There are 4 types of osteogenesis imperfecta. Type 1, which is the mildest form, usually with normal stature, blue eyes, and is of a dominant inheritance. Type 2 is the most severe, which is a perinatal lethal form and is a dominant mutation. Type 3 usually is a progressively deforming type, rarely recessive, unlinked to type 1 collagen genes. And type 4 is mild to moderate and is of dominant inheritance. 90% of the individual have mutations of pro-alpha-1 or pro-alpha-2 chains of the type 1 collagen. Bone fragility is the cardinal manifestation. As a patient, the anesthetic management is basically fragile, handled with care. Hypermetabolic state is present, and you can see hyperthermic states, which is not associated with malignant hyperthermia. There is also platelet abnormalities associated with an easy history of bruising. Though bleeding and hemorrhage is rare of these patients, 30% have abnormal bleeding times, capillary fragility, and reduced levels of factor VIII. So it is recommended that platelet counts and standard coagulation tests with platelet function tests and factor VIII activities be tested, especially in those patients with a history of bleeding issues. Trisomy 21, 40% abnormalities of the cardiovascular system is seen in this patient. AV canal of those are 40%, VSD is 25%, and ASD is 10%. These patients are atropine sensitive. The allantoaxillary subluxation is present. Macroglossia, micronathia, subglottic stenosis makes these airway management difficult, as well as they are prone to immunosuppression. Juvenile rheumatoid arthritis is characterized by synovitis and extraarticular manifestation. Airway difficulties include temporomandibular joint alkalosis, mandibular hypoplasia, reduced neck extension, cricoid arytenoid arthritis, and glottic narrowing. There is also allantoaxillary subluxation. Systemic involvement is not usually as compromising. Iron deficient anemia. It's the most common anemia, usually results in microcytic hyperchromic anemia. Test is usually by serum ferritin concentration, and cyanosis is not discernible until hemoglobin is below 5 grams per deciliter. Severe anemia can lead to delayed wound healing. Physiological anemia is the conversion from fetal hemoglobin to hemoglobin A. Hemoglobin concentration decreases from 17 grams per deciliter to 10 grams deciliter at 8 to 12 weeks of age. Persists until the second half of the first year due to decreased level of erythropoietin, and usually this physiological anemia is asymptomatic. Sickle cell disease is a pain syndrome associated with anemia and its sequelae, can lead to organ failure and infection, has many comorbidities. Sickle cell disease has a structural variant in its protein of the hemoglobin. Hemoglobin S, the GAC sequence, is changed to GTC, where you have a glutamic acid with valine. Hemoglobin C is GAC, leading to AAG, where the glutamic acid is with lysine. Thalassemias, there is a decrease in the globin chain. There is a high heterogeneous disorder, both clinically, noted cellularly, as well as at molecular level. Sickle cell disease has a higher risk for perioperative morbidity and mortality. It's important to avoid dehydration. Transfusions are associated with improved perioperative outcome, and it's important to maintain normal body temperature, preserve cardiac output, avoid hypotension, elevate oxygen saturation, avoid vasoconstrictive situations, and control pain. Malignant hyperthermia is caused by the mutation of the ranitidine-1 gene, which produces an enhanced activation of the ranitidine-1 by the intraluminal calcium and leads to decreased thresholds for spontaneous calcium release during stored calcium overload. Its metabolic dysfunction is seen by the increase in intracellular ionized calcium overload, which results in increased intracellular ATP need to drive pumps. This intracellular ATP increase leads to the pumps to transfer calcium into the sacroplasmic reticulum, across to the sacrolemma, into extracellular fluids, or into the mitochondria. This increase in ATP is where manifestation of malignant hyperthermia is seen. Associated disease of malignant hyperthermia includes King-Denborough syndrome, central core myopathy, ranitidine-1 mutation, multi-mini-core disease with ranitidine-1 mutations, multi-mini-core disease without ranitidine-1 mutation, maybe, Niemelin-Rod myopathy with ranitidine-1 mutation, ranitidine-Rod myopathy without ranitidine-1 mutation, maybe. Preventive management of malignant hyperthermia is to use non-triggering anesthetics, rely on regional techniques, as well as the use of total intravenous anesthetics. Postoperatively, usually vital signs are checked, including EKG, dipstick of the urine for protein. A minimum of 1 hour recovery time is recommended. Acute management of malignant hyperthermia is to stop any triggering agent, possibly discontinue the procedure, hyperventilate over 10 liters per minute with 100% oxygen, dantrolene 2.5 milligrams over 5 minutes and repeat as needed. Initiate cooling activities to bring temperature below 39 degrees Celsius, including cold IV saline at 15 milliliters per kilogram over 10 minutes, ice pack, body cavity lavage, and the use of sodium bicarb 1 to 2 milliequivalents per kilo to correct any acidosis. Treat hyperkalemia with either insulin or even calcium if necessary. ACLS dysrhythmias treatment. Keep urine output at 2 milliliters per kilogram per hour with either the use of Lasix and mannitol and the placement of arterial lines and central venous lines for monitoring. And repeat blood labs every 15 minutes until the patient is stabilized. Summary. We focused on the disease process seen more frequently by pediatric anesthesia. A general understanding of the disease is needed, but more important is to understand how the anesthetic administration is altered by the disease process.